Welcome, everybody, to another episode of the Doctors and Dollars podcast, where we discuss health insights and wealth secrets. I'm your host, Nate Crandall, joined today by Dr. Demetrios Lewis. Dr. Lewis is double board certified in anesthesiology and pain medicine. In 2011, he co-founded Innovative Pain Specialists after completing his fellowship at the Brigham and Women's Hospital of Harvard University, one of the top pain medicine schools in the world. In addition to his practice, he serves on the medical staff at Northwest Community Hospital, where he is actively involved in treating patients with pain. Outside of work, Dr. Lewis likes to spend time watching Chicago sports, traveling, cartography. We're going to ask about that today, and being with his family. So welcome, Dr. Lewis. What's going well today?
Thank you. Thank you for having me. Appreciate it.
We're filming this right before Thanksgiving. You had a half day today. What was the week like? Was it a little bit crazy before the holidays? Everyone trying to get in?
Yeah, everybody's trying to jam in at the end of the year because unfortunately we live in a world where insurance company has stipulations where they do these deductibles, and of course it's all or nothing by the end of the year. So usually hit October, November, December, everybody's reached their deductible, and lo and behold, once you got everything covered, you're like, well, I might as well get in as fast as I can to get everything done before the end of the year, before my deductible resets come January 1st. So it was a hectic week, but not too bad. Kind of took a light day today to get ready for Thanksgiving, so not too bad.
There you go. It's amazing how many people all of a sudden have pain in Q4 of the
Yep,
year.
yep, that is true. We are obviously busier at the end of the year. Again, a lot of it has to do with these insurance company resets for these deductibles. I've often said insurance companies could probably get a leg up if they would maybe have deductibles quarterly or even half years. So,
Mm-hmm.
quarterly, so that you reach a certain deductible during a certain point, quarterly or whatnot, then the rest of that quarter or biannually, you get it for the rest of the year, you get your care covered instead of having, so that, the system doesn't get over inundated at the end of the year. And I think that would ease the burden on the system towards the end of the year.
For sure. Well, hopefully there's like a health insurance provider that's listening or
Yeah.
will be listening to this and they're like, man, Dr. Lewis has a pretty good idea. Let's bring that to the board. But
Yeah, or at least,
you never
yeah,
know.
they could be the only one that does it, and then maybe more people will sign up for their coverage.
For sure. Love that. Well, I want to dive in. So I want to hear some kind of the origin story of what got you going. But the big thing when we were talking offline, you're a bit of a history buff, right?
Right.
So much of that is in the knowledge of world history. But more close to home, you are a third generation physician. Grandpa
Right.
was general practice. Dad, who's still kicking, still with us at what, 98, 99 years old?
99, yeah.
Man, is a retired oncologist. Do you think that's something that does that family lineage, is that what drove you to be a doctor, or did something else early in life really spark you to want to get into medicine?
Yeah, I mean, I think obviously having family background is a significant portion of
Hmm.
wanting to do what I do, or am doing. When I was a kid growing up, um, my father oftentimes was like, "You're going to be a physician." This was kind of it. This was kind of only avenue that I was going to take, and he was. My father was very proud, and my family is very proud of the lineage we have, and the history we have, and the contributions to medicine. And I think that sort of that proudness kind of really kind of pushed, and it was instrumental in trying to have my father's kids, obviously me and my sister, but me specifically follow into his footsteps, and my grandfather's footsteps. So I think that definitely played a role. Growing up, you know how things are when you're a kid. You're not truly interested in school until you get a little bit older in life. And
Hmm.
I enjoyed academics a lot more, obviously, end of high school towards college. And then I took a year off between college and medical school. And I really sort of became ingrained in medicine more and really enjoyed it more when I was in medical school, and then going in through my clinical years of medical school and then in residency. And I really yearned for just that knowledge, and learning so much about the human body, and internal and external influences on the human body, which I thought was just really incredible. And the human body is just incredible, and the
Hmm.
things that we can offer in the technology and advances I thought was incredible. So I think that kind of shaped how, and how and what subspecialties I went into, and then ultimately, how I'm practicing today.
Yeah, so I mean, you're right. I think pride takes a big factor into that. You see the quality of work that your dad is doing. Probably didn't see grandpa's work, but um, just to know that they're helping people. Obviously, your dad is a former oncologist. You see that, and then you get to medical school and you start learning about the body and all these different things. And it's like, man, my dad knows all this stuff too. It's kind of a wild thing to think about. What might be wild for him though, and I don't know if you guys have these conversations, maybe do, like talking about the technology that you have in your specialties today that he didn't have, and how you're able to, I mean, obviously two different fields between oncology and even anesthesiology and pain management, but all the technology you can talk about. What does your dad think of all that?
Well, I mean, he thinks that a lot of things in the advances as far as the sciences, he thinks are incredible. I mean, my father wrote a lot of articles. In fact, he was the first one to write an article on the use of combination chemotherapy. The article was actually written in 1954, and it
Wow.
was before that there was a kind of consensus that that was the actual standard of care. Should be the standard of care is combination chemotherapy in cancer treatment. And of course, he never really got the credit. He was part of this group called Midwest Cooperative Group, and the Eastern Oncology Group got more of the credit than he did. But um, you know, he would always say, "Hey, with the internet is an incredible thing. It's just amazing how nowadays you can type things in Google, PubMed that we use in medicine all the time. It's readily available online. You just type in a couple keyword searches, and boom, things come up, and you have so much at your fingertips in which you can use as references for your studies. I mean, you look at back in the days when you're writing papers in 1954. I mean, you would have to go to the library physically, go to the card catalog, find the article, find the journal article, look through the journal, see if you can find the article that matches with what you're trying to
Mhm.
write about. And if it doesn't, you have to go to the next journal, and you're just wasting a lot of time. And I think that's why the dawn of the internet has really been, especially now, it's you have so much at your fingertips where you can quickly get references to kind of cite your literature and support your arguments for some of the uh, literature that you're writing. Um, my looking back at my family, we talked about that. My my godmother was also a pediatrician. My cousins that live out in the East Coast are physicians as well. So there's a lot of, and my brother-in-law is a physician. He's an orthopedic surgeon, and so there's a lot of medicine in our family. So
Mhm.
oftentimes we'll talk a lot of healthcare stuff, a lot of medicine stuff in our families for holidays and stuff like that. So it's something that's always been kind of discussed around the table, and so it's I mean, it would be, I'm sure if my dad was practicing medicine today, he would feel the ease of being able to easily complete
Sure.
papers and write all these journal articles, that it was a little bit more challenging, obviously, in his day.
Yeah, for sure. Well, great thoughts there. I love that. Uh, Two of my thoughts then. One, I haven't heard the phrase card catalog since I was in like sixth grade. So good name drop there.
Yeah.
Other one being around PubMed, because obviously that's used everywhere. How often do you find yourself or peers of yours truly diving into PubMed and using that literature for whatever it is that you're searching it?
I mean, I mean, to be honest with you, I'm almost on it daily.
Mhm.
Not just, it's just a lot of things I'm curious about. I have patients that oftentimes ask me questions, and as a physician, in the realm of knowing medicine, you really can't know everything in medicine. It's
Sure.
literally impossible. But again, we have these things at our disposal, which make things a lot easier. So we can easily, head over to PubMed and just kind of peruse PubMed and, you know, solidify our arguments, solidify things that we're doing. I think are very beneficial. I mean, using PubMed as a resource to legitimize how you're actually applying the practice of medicine. You look at insurance companies a lot of times, you get back to them, they have a lot of regulations and guidelines, I always like to say, regarding, whatever tests, procedures, things like that. And oftentimes you need to head to PubMed to really boost your argument for why things need to be proved, because you're trying to prove that you're obviously adhering to the standard of care and you know
Sure.
the practice of medicine, what is really medically necessary for patients. But so I'm kind of on it. If not daily, every other day, just kind of perusing, as I said, to solidify my arguments for various things and to help, booster and treat my patients better so that I'm up to par with a lot of the literature and things that I may not even know. I want to, I want to get familiar with things, medications that have interactions with other medications for patients, things like that. If there's been studies, comparatives, things like that, I think are always beneficial to have those at your disposal. And it's great that we're able to practice in the days of now, that we can just close a window and then in our EMR and then look up another window and boom, you got Google and then you got PubMed right there and you could just look things up very quickly.
For
And
sure.
PubMed's pretty reputable because it's obviously NIH and it's the federal government where all the archives are stored, and it helps. So
Yeah. So it's used as a validation tool a lot of times when it's like, hey, I want to really solidify my reason for going back to this patient and giving the feedback that I want to, but also a learning tool. I mean, if you're a
yeah, I
super
think it's
smart
both.
guy, it's just more just, hey, I don't know this and I want to read about it.
Absolutely. Like I said, you can't know everything in medicine. And I think any physician that says they do is, I don't think many physicians would claim that, but um, I think that I think it's always important to know your limitations, not just in life, but in medicine, so that you can better treat the patient. And you will come to a point that you may not be able to help somebody, but at least you can always steer them in the right direction. Sometimes I always tell my patients, look, I may not be the one that's going to be able to help you, but at least let me be the one that's going to steer you in the right direction so that you can get the care that you need. And oftentimes patients are very receptive to that. They
Yeah.
welcome that and say, listen, this is great because, look, I know he didn't, maybe couldn't help me, but I'm in the right direction. I'm not wasting more time and money going here, there, and there. And so, these, again, having these advances in technology, not only so that you can help patients, but also help steer them in the right directions when you need to do things.
Yeah. And better to be that advocate than, be the one that's like, hey, I'm not the one that can help you. Sorry. And then they're going to WebMD or they're Facebooking their friends to say, hey, I got this going on. What do you think I should do? Much better to be able to steer someone in the right direction, even though you're not the one that can handle that care.
Yeah, or you look at the other flip side too, is they didn't go to some other individual, other physician, and they got put in a ringer, and they got caught in a loop, and now they're wasting time and money, especially when the costs of insurance premiums are astronomical and people have sky high deductibles. I mean, that's really coming. That's really the bills being flipped out of the patient's pocket, and it's it's sad. You wish that patients wouldn't have to be, back even 10 years ago, things weren't as drastically bad as they are now. So, you always want to be, cognizant of that for the patients, because you want to be an
Mhm.
advocate for the patient, financially too. You don't want them to waste their time and money if it's unnecessary.
Absolutely. Well, you're a pretty smart guy. Uh, you're at Brigham and Women's, right, doing your fellowship out there on the East Coast. Hopefully, you didn't turn into a Patriots fan while you're out there. You stayed true to your Bears fandom, but got you double board certified, anesthesiology and pain medicine. So obviously, you and Dr. Marsiglia, you started innovative pain specialists, really focusing on pain management. How often are you using the anesthesiology side of your board certification?
Right when I finished fellowship in Boston, it was around 2010. I did a lot more anesthesia. Did that for a few years. I don't really do as much. I mean, 2 to 3%. Do some minor sedation here and there, but nothing
Mm-hmm.
major. It's really oftentimes really hard to really be able to be there all the time for pain and anesthesia. As I said, I did do that in the beginning. My partner, Marsiglia, he also did that, and we both kind of did what was necessary, really, because we're independent practice, and we funded our practice on our own, and took it amongst ourselves to say, we need to do what's right, and we have to have funds, obviously, to keep this practice afloat. And we did that for
Mm-hmm.
good 4 or 5 years. And as I got busier with pain, I felt like I didn't really need to do the anesthesia side. You look at anesthesia, for example, anywhere where you can do anesthesia, a lot of times, in the operating room, either in the main OR in the hospital or even surgery centers, usually surgery starts about 7. You got to be there around 6, probably 6:15 to get adequately prepped for your cases. But then a lot of times you're not going to get out till like 3, 4 o'clock. And by
Hmm.
that time, your day's kind of shot. There's no way you're really going to be able to go and see patients. Some individuals have it divided up where they're able to do maybe a couple days of anesthesia, a couple of days of pain. Some groups are able to accommodate various physicians in that realm, and that's great. I had a little bit of that when I was in Boston. I was at a private hospital just south of Boston. I was kind of doing both, maybe like 1 or 2 days of pain and 3, 4 days of anesthesia. Mix it up a little bit. I do love anesthesia. I think anesthesia is a great subspecialty of medicine.
Hmm.
Um, it's very it could be very nerve wracking. A lot of things could go awry in the operating room, and it's really split second decisions, really life or death as an anesthesiologist, and it keeps you on your toes. But as I got a little bit older, I kind of like to do things more. We're like, okay, hey, I'm seeing a patient. It's a little bit more relaxed, laid back atmosphere. We still do cases in the operating room as pain. We do some
Hmm.
surgeries and interventions and things like that, but stressful, but not, I feel like not as stressful as it was for anesthesia. And like I said, trying to combine the two would be very
Yeah.
challenging, but I'm very grateful that I had the opportunity to obviously study both. Obviously anesthesiology and pain management sort of go hand in hand. Really pain management is a subspecialty of anesthesiology because really it's
Mhm.
pain is analgesia, right? And so it's the study of analgesiology is really what it should be called instead of pain management. But I always said pain management is like the worst subspecialty name that we could ever have because you look at it and you have pain and it's like pain is just really a symptom, right? It's just like okay, so how do you apply that? But it is what it is. But now I'm really just 100% pain. And it's been great. It's been great. I really love what I do. I love my patients. I love helping patients is really satisfying. I think that when a patient comes in with a really bad issue, and a lot of physicians do say this, and this is one of the gratifying things about being a physician is you can really help somebody. And when somebody is able to say, "Oh, now I can walk around, do things at home, or I can go to the gym and I can go, work out or whatever it is they do, even just simple daily things, walk around the neighborhood with their dog." I mean, it's satisfying, and patients are very thankful, and that's one of the good things about uh, being a physician is you always have that kind of gratitude, and it's humbling. So
I feel like you saw my notes or something, but just for the audience, I didn't share my notes with Dr. Lewis for mine. Literally, next question was like, talk to me about your feelings when someone comes to you with chronic or sometimes debilitating pain, and then they show their gratitude after you've been able to help them. And you literally answered my question already, saying it's extremely satisfying. You're able to impact and change someone's life on a one-to-one scale. That's just there's not a lot of jobs out there that you can do create that kind of impact, immediately for someone.
yeah, because it's I always explain to my patients, pain sucks. Yeah,
Hmm.
you just put yourself in this situation. You ever have a situation where you've had it's a weekend, you're with your family or something, and then something happens, right? You throw out your back, you throw out your shoulder, a bad toothache, whatever it might be. It's really debilitating sometimes. I mean, all
Hmm.
your mind is able to focus on is that one simple thing, and everything else is sort of erased and is arbitrary compared to what
Yeah.
that issue is. And until you get that issue addressed, nothing else matters.
Yeah. Or everything is annoying, right? You're just agitated at everything else because it isn't fixing your pain.
Right, and they've done studies on that. They've done functional MRIs of patients' minds with pain as an emotional, because the same part of your brain that lights up with pain is the same part of your brain that lights up for a lot of the emotional aspects, such as mood and where you're happy and you're sad and things like that. And I often tell my patients is like, if you're in a bad mood, pain's always going to be worse. But when you're in a more relaxed, comfortable, less stressed atmosphere and mood, pain will not be as bad. Your pain may still be there, but it may not be as
Hmm.
bad. And that's the whole principle of, for pain, the psychological component of doing things like cognitive behavioral therapy and teaching people about coping skills and relaxation techniques that I think are very beneficial for patients, because not everything is going to be necessarily corrected with just a simple injection or a simple pill. A lot of it
Hmm.
is going to be the psychiatric, emotional aspect that needs to be treated as well.
Yeah. Do you guys integrate some of that into your practice as you're treating patients? Obviously, there can be the injections and different medications for pain management, but do you guys talk about some of those cognitive
Yeah,
therapies as well?
absolutely. Absolutely. And we work with pain psychologists all the time to, teach these patients these skills. And I think it's very imperative, because I think they can, if they learn how to control those things, I mean, I think that helps a lot. As again, as I said, is the overwhelming emotional aspect that can really overtake and make pain sometimes explode. And once they learn those techniques, it can be beneficial.
For sure. Well, I love that you shared your journey about and really the relationship between anesthesiology and pain management. Obviously, anesthesiology is probably the first thing you were thinking of because pain management being the kind of the subset, right, of that, like you shared. We had an anesthesiologist on the episode last week. Uh, he said it can be very nerve wracking, like you said. He compared himself to like an airline pilot. Like I'm there for the very beginning and I'm there for the very end. Takeoff and landing. Those are the critical parts of a surgery. Uh, from an anesthesiologist standpoint, you're there beginning and end. A lot of stress, pain
Yeah, usually
management.
it's not to interrupt. My apologies,
No,
but
you're
it's
good.
usually the landing that
Is the hard
oftentimes
part.
is. Yeah, it's so I had an attending when I was at Rush, and he used to always say anybody can intubate. It's just extubating is the more difficult, because that's
Mm,
what things can go awry, right? You pull out the tube, you lose that secure airway. If they go into spasm, things like that, they can close off their airway, and a lot of things can go awry. So he would always oftentimes argue that sure, you can put a tube in somebody's throat, but can you take it out safely enough that they can breathe on their own and secure their own airway without any other sequelae that may arise at that time? And that oftentimes is a challenging part. And he oftentimes might be right. I mean, I've done this obviously for 12, 13 years, and I can tell you that oftentimes extubating is often worse than putting the tube in.
yeah.
So it really is taking off and landing the plane. And you're right, once you feel like you're midair and you're sort of on cruise control, hoping that the surgeon doesn't do too many things to mess up, so that you're really trying to stabilize the patient. But as an anesthesiologist, you're really the captain of the ship. You're trying to keep things afloat, and you got to work in tandem with the surgeon, and
Hmm.
that's when you'll always have the best outcomes for patients.
For sure. So, how much surgery do you guys do on the PM&R side? Is it non-invasive mostly, or kind of fill me in on how that goes? And does your anesthesiology background kind of help with that if you need to?
Yeah, so we do. Um, my practice is mostly interventional based.
Perfect.
I don't
Okay.
really do too much medication management. Of course, I have patients on
Mm.
meds. I try to focus on the intervention side, because I look at it this way, that um, I'm more of an alpha omega type of person. So there's a beginning and end. So if somebody has pain, there's got to be a source. Something's got to be awry that's causing the pain. And once we can find where the pain is coming from, the pain generator, um, then we're cooking with gas. Then we can finally start to adequately treat the patients. I oftentimes find that patients don't get benefit with interventions or surgeries that they have, is because the diagnosis wasn't correct.
Mm.
I'm convinced, and it could be wrong, maybe other physicians would disagree, but I'm convinced that if the diagnosis is correct, your treatment will be effective the majority of the time, if not all. So if we have a treatment too, that's
Right.
that's that's important to
Fair.
know.
Yep, that's fair.
But we do interventions, and that can be simple injections, nerve blocks, joint injections. Um, a lot of times injections to the spine, epidurals, small nerve blocks. We do ablations of nerves.
Hmm.
We do implantation of stimulators either in the spine or in the in the periphery, small nerves in the periphery. We do some minimally invasive decompression of the spine for patients that have what's known as spinal stenosis or narrowing of the spine. We'll do some ablations into the spine for patients with chronic pain. So there's a lot of different, we do what's called kyphoplasties, vertebroplasties, where we'll put cement into the bone in the spine for patients that have compression fractures. So there's a lot of things that we do less invasive. They're not really major surgeries by the most part. They're more just minimally invasive to help bridge those patients with pain, hoping that you don't have to go on to that next step of surgery. Obviously, patients
Mhm.
that either fail conservative treatment modalities, and I would say that in that realm of meds and physical therapy, and then with interventions that pain can do, pain management, those patients that kind of fail those can move along towards that intervention, the surgical aspect if need be. But it's really blossomed into that algorithm of right before you've seen your primary doctor or internist, and then you're going to, or you were in the ER or something like that, and you're trying to physical therapy things, and those aren't working with the meds and stuff. And then before you really even need to get to the surgical realm, you kind of hit then the pain management realm, and that's really where it's found its course. And then those patients that, again, as I said, that fail, then we'll move on to the surgical realm, or those patients that have like significant issues that really need to get to the surgery. And I think that, as pain physicians working in tandem with our surgical colleagues, I think is very important because patients oftentimes will get the best treatments when we work in tandem with each other, as well as the internal medicine specialists too. I mean, we work all in sync with each other, and you kind of move patients along this continuum. And sometimes it's like a slide, so they may move back and forth depending how they're doing. If they're getting better, then they'll slide back towards their, primary care doctor, internist. And if it's getting worse, they'll slide back to the surgeon. And obviously we're kind
Yep.
of like management middle. So, um, but we focus mostly on the interventions because I think that if we can, even if we can't help the patient, as I said, we can at least help diagnose what the pain is actually coming from. For example, you got a patient that has significant spinal stenosis in the lumbar spine, and it's sort of riddled throughout their lumbar spine. You always ask the question, and oftentimes with patients elderly, it's very hard to kind of pinpoint, okay, well, where's the pain coming from? Is it in the lower spine, mid spine, upper spine? Where's the pain kind of coming from? And not only doing MRIs and things like EMGs and obviously physical examination and their symptomatology based on dermatomes and things like that, but if you can even use an injection to pinpoint exactly where that may come from. And if they get exceptional relief with an injection, one or two injections at one focal point, but maybe it doesn't last a long time, at least when they go to the surgeon, we could say with more certainty, hey, look, this is exactly where they have pathology on the MRI or EMG or whatever modality you use, CT scan or X-ray. And we do these, they've failed these things, but we did the interventions. There's symptoms associated. It sounds like this is really the sweet spot. And eventually the surgeon, operates around that area. Patients should probably have a better outcome. So I think that's working all together in a sort of symbiotic relationship that we can kind of move patients through that continuum. I think they always get the best results.
I love that. Thank you for sharing all that, because I hope that there's people that hear that, that listen to the show that are in pain and they're like, man, I've gone to my primary care provider. I'm still feeling the pain. I don't know where to go. What's my next stepping stones? I had this similar conversation way back on episode 2 with Dr. John Santa Ana. I don't know if you know him. He's up in Michigan, PM&R guy that, he was kind of talking about the stepping stones that you did as well, and how many people will go to their primary care, they'll get referred over to physical therapy, they'll fail out of physical therapy, and their next thought is like, oh, great, now I have to have surgery. And they kind of skip over the PM&R side and the interventional stuff that you guys are doing, which I think is, after having all these conversations, understanding how the flow works, I feel like you guys are the most important, because you have the ability to stop it there. You have the ability to say, hey, maybe you're not quite at our point, go back to physical therapy, try it again, or you're beyond our point, you've reached the severity to where surgery is needed. And so I think you play a critical role in I guess the pain threshold, I guess, if you want to call it, starting from A to B. You guys are that kind of pivotal point of deciding, sliding back and forth, how that happens. And I think I don't know if that's something that you saw when let's go back 13 years. And as you were coming out and you're getting everything started, even maybe before innovative pain specialists or as you guys were setting it up, did you see yourselves as that pivotal point within that spectrum, or was it more just, hey, we want to take care of people's pain?
I would say no. I didn't
Hmm.
see it that way when I was coming out of residency fellowship. But I
It's a
also
beautiful thing.
it is, but I also feel that it's part of the problem too is they don't really teach you that when you're in sort of yes, you go through those motions, but you don't really understand. Um, I think a lot of times as your physician, you blossom. You really do, and your mind changes, and that happens in a lot of um, avenues of different people's work, so specialties, things like that. I mean, I think that
Is that
uh,
happening in residency or fellowship, or is it once you're attending, that's where you really figure yourself out, you figure out where your place in the world is? When is that blossoming happening?
yeah, I think each step along the way you're making
Okay.
changes. But I also think that I knew a lot more as a fellow compared to when I was a resident. I had a better grasp of anesthesiology, but I was also taking my boards. And then so you're really immersed in the books and you really know as much as you possibly can.
Sure.
But then when you're out in the private practice and then you're sort of really seeing the gamut of a lot of things that you haven't seen before, right? And there
Mhm.
are some things, you train at some of these universities, right? I was at Rush and I was at Harvard in Boston. And yes, you do see a lot of things that you won't see in the community because they're university hospitals. So they're going to see the gamut of these
The
disease
wild
states.
stuff.
Exactly.
Hmm.
They're going to see the stuff that you're not going to see in the what we call the bread and butter things in the community. Um, but there is a time when what happens is, and I used to be a surgical resident actually for a couple of years before I switched into anesthesiology.
Oh,
We used to there used to be a joke with a lot of the senior residents would joke and they would say when you get I forget how they stated it out. I may botch this, but it was sort of like the white wall syndrome or white wall stare. Whereas you're in the middle of doing a surgery and you're getting to a point you're like, oh man, I don't know what I'm doing, and you like look up and your attending's not across from you and it's just a blank white wall because you're by yourself. And then you're like, oh yeah, I'm by myself. This is now the show is on me, and so you got to figure it out. And
hmm.
that usually happens like in your first kind of year or two after you're getting out of residency, out of training or fellowship, and you're like, the buck stops here. The dime is on me. I have to figure this out for the sake of the patient. I can't really. I mean, sure, you can always ask your colleagues and things like that, and a lot of
Hmm.
times you're in bigger groups or you're in a hospital where you can ask guys that are a little bit more savvy or have been in practice for a long time, like, hey, what do you normally do when you see this or this? And like, oh, I usually do it like, and you're like, okay, great. And you know what I mean? You get that sort of mentoring as well. But
Yeah,
but
but you
it's so
can't when you're
important,
scrubbed in and you're right in the middle of it, and all of a
right? Well,
sudden you look across and you
it
got a
is
white
what it
wall. You're
is.
like, oh yeah.
It is what it is. That's when when you see the blank wall. But I got a lot of my buddies that are, they're all, well into their surgical practice now, and I'm sure they feel the same way. I mean, you learn a lot as you get towards you're into your fifth, sixth, 10th year of practice, and you're just it becomes just like you become a well-oiled machine. You just kind of keep going and going, and you've seen the things that work, you see the things you're like, I'm not too sure that that's going to work, and so and you get a better sort of idea of how really the whole system works, especially when you're in private practice. I think when you're an employed doctor at like a hospital, it's hard. I don't think you get that of
Bit of a
how the
bubble.
system works with like a lot of stuff with insurance companies and obviously running a practice on your own. It's very eye opening. Like I said, my partner and I, we've been in practice for over 12 years, and it's a completely different experience than what you would have if you were at a hospital working for the hospital, because you're not going to have to see some of the things that we have to see in private practice or even have to deal with. You're dealing with the business side of medicine, which oftentimes is pretty sad. Something they never teach you in medical school. They never
Yeah.
teach you business in medical school, nor in residency. I don't know why, because medicine, we always argue that medicine is a profession. I mean, it is a profession, but is it a profession or is it a business? One could argue now that
Mm.
medicine is a business. I often say you can't have both. It has to be one or the other. And from what I've witnessed is it's pushed into the realm of being really a business. But then if it is, then that should be taught in medical school. And if not in medical school, it should be taught in residencies to how to open a practice, how to handle business, how to, negotiate your insurance contracts, how to finagle with insurance companies when they're, denying you, when they're not allowing you to give patients care, when, how to handle, work staff, how to, all these things are never taught. And it's just one of those things where you just hit the ground running and figure out when you get there.
You get a glimpse of that, at least in, probably not like when you're, especially in the fellowship, but like even within medical school, is there any type of instruction on how you guys have to coordinate and deal with insurance companies and patient care and things like that? Is there any of that in medical school at all, or is it just you
Yeah.
just
So
kind of say,
sometimes,
hey, insurance helps pay or people pay out of pocket? That's really the two ways to
well, and
skin a cat.
unfortunately, that's usually it is. It's black and white like that. It is.
Hmm.
But what happens is a lot of times in medical school, you'll actually get a chance to rotate with some private practice.
Okay, good. Yeah.
So you'll get a little bit of that. But when you're a third or fourth year medical student, you're really not thinking about that. What you're really thinking about in third and fourth year is like, oh man, I got to take my boards. My second board is the USMLE step 2, and then I got to start applying for residency. Where am I going to go to residency? And like all these things in your mind, I got to make sure I do well in this course so that it reflects good on my grade. It's going to help me for residency, whatever residency I'm going to apply for. And so you're really going through all those things, and you're thinking about the business realm of medicine is sort of the last thing in your mind. But that I just think that there could be. I think having more external um, physicians coming in and really just kind of giving people like the medical students or residents, like I said before, you can do it later, but like just better glimpses into how things really work in the what we always like to call it the real world experience. I mean
Sure.
that's how it is. It's a little bit different. And I worked for a hospital, as I said, when I came out of fellowship for a couple of years, and I didn't know any of this stuff. None of the stuff that I was doing there that I was even A, concerned about, or B, knew anything about. And then when we opened up our private practice back here in Chicago, it was um, it was an eye-opening experience because you make mistakes, and making mistakes is fine because you learn from your mistakes.
Hmm.
You can curb your mistakes because mistakes could be financially a burden. Um,
Yeah.
you want to try to curb those as much as you can, and having some guidance, from I think having at least resources from external physicians that have done this before would be beneficial, and hopefully it'll change. I think it needs to change, and I think it'd be beneficial not just for physicians though, not for physicians to be independent, but I think it's better for patients. Patients should
Mm.
have that selection, right? I mean, we live in a free country for the
Hmm.
most and you would think that, okay, I have insurance. I pay good money for it. Not only do I pay good money for it, but I also have to pay a lot of money when insurance doesn't pay because I
Hmm.
have a high deductible or whatever it is. So I should be able to have that freedom of choice to go to the physician that I want.
Hmm.
I mean, that's true freedom of choice, not that where my insurance company is going to steer me to go to or what hospital system is going to steer me to go to. It's kind of like I should be able to have that freedom of choice. So if it's either this guy, or this guy, or girl, or whoever, woman, or whoever it is, not to be discriminatory by any means, but I'm just trying to say is whoever it is, you should be able to have that choice, and hopefully that will change. And it used to be that way, but there's been a lot more, unfortunately, a lot more controls behind the scenes, and so a lot of patients kind of lose that choice, that freedom of choice.
For sure. No, that's good thought there. Let's talk about innovative pain specialists. So, like, was it the move from the East Coast back to Chicago that prompted you to go into private practice? Was it you had a great external physician that came in while you're in medical school or residency, like you were talking about earlier, that really sparked that? Like, hey, when I'm done with all this, I want to go into private practice. What really drove that? Or was it simply I wanted to be back in Chicago and I didn't want to go work as a W-2 employee at a hospital, so here I was.
Yeah, well, I didn't really want to be an employee at a hospital, but
Hmm.
I also, my business partner was like, "Hey, we should open up our own practice."
Yep. Was he there in Boston with you as well?
Yeah,
Okay.
and I was like, okay. And, you hear, you would talk to your attendings, and your attendings, don't forget, we're at universities. So they'd be like, you would hear from a lot of other people, oh my God, you're nuts. I can't believe you're going to do this. It's going to be an epic failure. The hospitals are trying to take over everything. The insurance companies run and take over everything.
Mm-hmm.
Okay. Maybe I'm insane, but, I'd like to take that leap. And we did. And, it gave us an opportunity to come back to Chicago. We really wanted to come back, and both of our families were here. Um, I had a 2-year-old son at the time, and you know, I think in life, when your back is against the wall, failure is not an option.
Mm-hmm.
And we just didn't let ourselves fail. I did everything in my power to work, doing moonlighting. I used to moonlight 72 to 84 hours on a weekend straight to make money. And then I would use that money and I would put it into the practice to keep the practice afloat. I would work doing some anesthesia on the side, between seeing patients in the clinic, and take that money and put it into the practice to keep it afloat, or use that money and try to keep my family afloat until I had an established practice where I could then wean off of having to be dependent on, full anesthesiology. And we worked with a great, partner of ours who is he owned an anesthesia group in Chicago, did a lot of like mobile anesthesia, and he was a godsend for us. I mean, he's still a good friend of ours today, and he really helped us out because he gave us these opportunities to make the money that we needed to, not just to keep our families afloat, but also to help keep our practice afloat. Um, when I look back at it now, I don't think I would want it any other way. I'm very happy
Mm-hmm.
with what I accomplished. But again, I think that you have to have that mindset, and you have to have that mentality that you're going to, when push comes to shove, you cannot let yourself fail. And it's just not letting yourself fail. But, again, I had a son at the time. I couldn't let my family fail. So,
Mm-hmm.
um, and, um, and that was kind of why we went into private practice. I kind of also, I really do enjoy setting my own hours. I mean, I worked a half a day today. So,
Mm-hmm.
now my wife now is like, hey, can you take off, uh, 2 days after Christmas? Okay, I'll just take it off. I mean,
Mm-hmm.
just change my schedule around and do it like that. But when I was, working at the hospital, that really wasn't an option. It was really like, okay, well, you have designated days these days, and otherwise you have to come in.
Mm-hmm.
So, but now I have that freedom. I have that freedom where I can change my schedule. My father was independent. My grandfather was independent. And my dad would always say the same thing. He's like, the beautiful thing about being a physician is you have that freedom to really manage your schedule. But the problem now is that more and more of the employed model system, you don't really have that freedom. That freedom is,
Mm-hmm.
is lost. And I think that that was one of the reasons, another reason why I wanted to, um, be independent, so I can have the choice of, doing these things when I wanted to. Plus, deciding how I really wanted to treat patients, not having to, do things based on what are called RVUs to try to build up more revenue for the hospital so I can get paid more. It's like, no, I just do what's
Mm-hmm.
right for the patient so that the patient could be on their merry way. And if I do what's right for the patient is more likely to refer one of their friends or the families or their colleagues to me because they know they got the best care.
Hey everyone, I wanted to take a moment to talk about what I do outside of being the host of the Doctors and Dollars podcast. I'm the CFO of Grand Vision Capital Group. At Grand Vision, we work with high income earners who make a great living but still can't quite break through that true wealth ceiling. We utilize strategically chosen investments tailored for high income earners. The question always at the forefront of our minds is, why wait for retirement to finally live when you can implement an investment strategy that will impact your life today? To be honest, most of the people we work with never even knew these options existed because their financial planner doesn't have access to these exclusive investments. So, if you're ready to finally turn your high income into real wealth, visit our website, www.grandvision.co, and hit the Take Action button in the top right corner to schedule some time with me. Or even better, connect, follow me on any of my social media accounts, shoot me a message. Now, back to the show. Yeah, I mean, you could just feel your dedication to it. I love it. And obviously, you have love your family, there's everyone calls it the work-life balance, right? And I feel like when you're in private practice, I wouldn't call it work-life balance. I would call it life. Like, right? How do you just balance life? And being in private practice, not having, minimum requirement of hours that you have to work at the hospital, you just don't have those different strings tugging at you, allows you to not only create a better life balance for you and your family personally, but it's all, like you said, it's better for your patients, right? You might be hey, I only want to work until 2 o'clock every day. And you might get a lot of patients who are like, good, I want to see you in the morning. Like, I don't want to come see you at 5 p.m. Because that's the end of my day. So I just think the dynamic that allows a private physician to be able to interact with their patients is just so much better than, in a private practice setting than it is in a hospital setting. Would you agree with that?
Yeah, I mean, by no means am I would,
Not
me.
poo-pooing on hospital
Yeah, I mean, it's
physicians,
but
not at all. I'm just saying.
right, right. By no means would I do that. I just feel, what's right for me, um, and how, it also depends on how you look at things. I look at the world probably differently than some other physicians may look at it.
Mhm.
I I often tell patients, I'm like, look, you know who my boss is? My boss is the patient. That's my boss.
Mhm.
Really are,
Unique,
because
yeah.
my patients are going to tell me whether or not I'm doing the correct job. Because if I'm not, I get fired, but I get fired from them. And so that is a stain on me, because it's a stain on me because now they're not going to refer patients, like I said, friends, colleagues, family, things like that. So, you know, your number one priority is your patient. And I think that, I have some friends that are, are in the employment model, and it works well for them, and they like it. And they wouldn't have it any other way. And that's, you know, different strokes for different folks, right? Everybody to
Yep.
their own.
Yeah.
But and that's fine. But and then I have some other friends of mine that are in the independent model, and they love it too, and they wouldn't have it any other way. So I think it's really, it's really what you yearn for, what you want to do. What do you really want to accomplish in medicine? Do you want to just kind of go in, have patients already readily available for you, and then the hospital just supplies you with some patients, and then you see them, and then you kind of go home and call it a day?
Mhm.
Or do you want to try to build up a book of business and build up a practice where your your word and your reputation is everything? Because I'm no different than, going to a small mom and pop restaurant. If
Mhm.
I'm not serving quality food, nobody's going to come back. I'm not going to have just clients thrown on my doorstep for me. I have
Mhm.
to go out there and earn it. And that's the difference between the independent model. But, and like I said, to each their own. I mean, everybody has, different, different things that they want to accomplish, and how they view what they want to do, and how they want to live their lives, and how they want to balance their lives. And that's why you obviously have these two models really available, and physician has that opportunity to pick and choose what they want to do. So for me, the model was the independent model, and I've always yearned for that. I like to, you know, just have that independence, and that works for me. And then there's some employed physicians that do have more independence. I think
Mhm.
it all depends on how things are structured. I also think it has to do with subspecialty and how they're able to negotiate contracts and things like that. Those things taken apart. But some of those guys that are more independent are a little bit more savvy in their employed model, maybe because they had experience in the independent realm first, and then they were able to negotiate.
Learned.
They
Yep.
learned, and they were able to negotiate what they wanted. Whereas a guy that somebody that came fresh out of residency or fellowship, you're wet behind the ears. You don't really know what it is that you're really trying to negotiate. Again, comes in that business savviness and that understanding of what to ask for, what to look for, what is it that you really want, in the um, how to practice day in and day out. And I think that's important. And maybe it'll change. Maybe um, people in medical school and residency like that will have a little
Mhm.
bit more access to that, and that will help them be a little bit more choosy in when they're getting out.
Yeah, I mean, talk about savvy though. That's a hell of a perspective to have. Like, you work for the patient. I think that's awesome to have that perspective. And so that's a great segue into my next thought. Is
But I
like,
mean, if you think, not to interrupt you, but if you think
no,
about
you're
it,
good.
forget about the insurance companies. Let's go back to the old model. Let's go back to the old days. Really, insurance companies. I mean, insurance companies have been around, '30s and things like that. And you look at
Hmm.
really healthcare insurance companies. Yeah, some of the subsidiaries have been around for a while since the '30s and stuff, but really they didn't get their start until '60s, '70s, '80s. And they really got involved in obviously paying for the fee for service for the doctor, because the patient would then pay obviously for their premium. But if you if you think about it, before that, the patient had a problem, the patient came in, the doctor fixed the problem or helped solve the problem, and the patient would pay the bill. So really, that's not, obviously it's your patient, but it's your customer. So it's no
Hmm.
different than a guy installing HVAC, and
Yep.
he was in. He's like, I gotta install a new furnace. I come in there, I provide the furnace, I install it, make sure my quality is good. The person pays the bill. The client pays the bill. There's my word. There's my,
Hmm.
if I do great work, I'm going to get more referrals. So in essence, in the side of, like, for example, using the example of heating and air conditioning, their boss is really the client they installed. Same thing as a
Hmm.
physician. Boss is really the patient which you provided the services for. So if you're kind of using that kind of old model of the patients actually paid for the services, and there's a lot of patients that actually, a lot of physicians that have their practices that way, where they're more of a fee for service and don't really do insurances.
Yeah. I mean, you kind of opened my eyes a little bit there. I have this similar mentality. I just didn't think of it as the working for. Like, so what me and my business partner do with Grand Vision Capital, are essentially we work for our investors. And so like all of our conversations, all the decisions we make, are we going to buy this, apartment complex, or are we going to go buy this one? Like all those decisions and the numbers are based on what's best for our investors. I guess I've just never thought of it as like we work for the investors, right? Because you're right. They all of a sudden they could leave, right? They could pull their money. They're never going to refer anyone to us. But if they're happy and they're taken care of and we're doing what's best for them, they're going to be happy to refer. They're going to continue to come back. They'll invest more. I just never thought about it that way. So
Yeah,
I'm gonna thank you for opening my eyes in that type of perspective, because that's a great way to think about it.
yeah. I mean, it's almost like being a politician, right? You work for
Hmm.
your constituents. Your constituents voted you in. You work for your constituents who got you in there. You betray your constituents. 4 years later, there's a good chance that they're not going to vote for you again.
Yeah.
So, you look at it that, Rob, and I think if you apply that in almost in any walk of life that you do, whatever it is that, if you're, from having a restaurant, a grocery store, installing heaters and air conditioning, whatever it is, being clothing stores, whatever, it's really, I mean, your customer is everything.
Hmm.
And that's kind of no different in medicine, and you want to
Hmm.
help them. And that's the way I look at it.
For sure. Well, thinking of your patients, what is the next? What's the next big thing for patients? What's the next big shift in patient care? I asked just because I think about like I know we were talking. You used to do telehealth. That was kind of the big thing after the pandemic began, and a lot of places were doing telehealth. A lot of pop up telehealth places just started, out of nowhere. And that was kind of the big run. What do you think the next big thing in patient care is that's really going to transform, the gap or bridge that gap between, the physician and the patient?
I mean, that's tough to say.
Hmm.
I mean, this whole
Is
AI
it
stuff.
AI?
Yeah,
Yeah,
I mean,
I read your mind.
yeah, that's going to be probably the next big thing, where somebody's going to be able to go on the internet, kind of read out their symptoms, and there's already some companies out there that are already started to capitalize on that. Whereas, you're going to come out, hey, I'm not feeling great this morning. I woke up, I got a scratchy throat, or whatever. And I think some of these probably like urgent care places would probably capitalize on that, so they can even um, preemptively screen patients. But like I said, a lot of companies are already starting to capitalize on this, so that
Hmm.
they could, they could say, okay, well then, here's your symptoms. It gets tabulated. This is what most likely you have. This is what's going to be recommended to be prescribed. Now, to have a prescription, obviously you need to be licensed to be able to prescribe that, right? So you have to have a license in
Sure.
the state. You have to have, all the legalities involved. So, then it would probably move towards some physician that works for the company or whatnot that once it gets put into a pod or something, it gets put into that avenue where it goes directly to this guy, and then the guy reviews it and he's like, oh, okay, looks like, X, Y, and Z. Okay, all right, this is what AI kind of put out. Yeah, I kind of, agree, and then boom, you get your prescription or something like that. Or maybe they get a telehealth conversation with them or something like that. I think that's gonna be helpful. I think AI is gonna be the next thing that's also gonna probably help in like the emergency rooms. I think that
Hmm.
is gonna help with triage, because you're gonna, this whole thing where patients are just like kind of sitting in the hallways now. It's actually gotten worse and worse, and I can tell you why that's happening, but I don't know if you have that much time, maybe another time. But the I think you're gonna maybe limit time. You're gonna limit this inability to adequately get people in. So you're gonna improve flow, and I think
Hmm.
that with AI is gonna increase the flow and improve the flow with the log jam that kind of happens in the ER. And I can see AI being very beneficial in that, and I think it's going to have other helps with diagnosing. There was something I was just reading the other day with AI that is for breast cancer, for better diagnostic and for quicker diagnostic, whether or not patients are having this. And, we already had genetic markers and things like that they were doing. And a lot of these things were coming out a couple of years ago. If you remember, there was like Cologuard and things like that, where you send your
Yep.
sample in, ask for some of the, obviously the DNA genetic material, and they would have all these markers and things like that. They would be able to
Hmm.
tell whether you have a higher risk of different carcinomas and things like that. So I
You're
think
talking more like from the radiology standpoint, they'll be able to read.
radiology too, but I also think like from a radiographic standpoint, they'll be able to tell things or pick things up, maybe small little markers that may not
Yeah.
be seen from the human eye, and they could be programmed to pick up those things maybe quicker. So I think that's going to be a major change in healthcare, and I think it's going to be a beneficial change in healthcare because I think you're going to have patients that can get more rapid care and more maybe concise. I mean, there is still an art to medicine. Medicine is really, a lot of people say, "Oh, it's a science." It is a science, but it's really art and science, and the art is when it comes to, I think, some of the surgical realms and
Hmm.
interventions.
Yeah.
the I mean, there is an art to diagnosing as well as trying to be methodical and going through an algorithmic approach for differentials and things like that. But I think AI is going to kind of that might take that out of the formula. So now it's going to be all artificially done for you, so that
Hmm.
and you would hope that no matter what happens, they still teach that in medical school, because if we get too heavily dependent on computers or technology, and God forbid one day there's something that catastrophically happens and we don't have that, at least we have the old school tool that we could still use our brains and figure things out.
Hmm. What I think AI can't replace, though, is the art of bedside manner, the interactions that you have with your patients one on one. Those right, those knee to knee, kind of bend over and have those conversations with them, the hard conversations. AI
Yeah.
is just not going to be able to do that. They can prescribe, they can provide you an outcome, but to actually deliver that's not something a computer is going to be able to do. That's always, I think, that will always fall in a position to be able to have that the art of speaking with the patient. I don't think you can replace that.
Right. Well, yeah, I mean, you hit the nail on the head. I mean, that comes with the art. Yeah, I mean, only time will tell. We'll see. I mean,
Mhm.
I think things have been progressing along with this AI now in the last at least 1 or 2 years.
Mhm.
It'll be interesting. I mean, I keep my nose in some of the journal articles. I'm always interested to read to see,
Same.
how are things changing now with AI, like what's going on, what's changing, and then it's and you sort of you curb and change your practice too to kind of keep that in the realm. And I think that maybe some of the EMRs will integrate some of the AI. I can see that happening too. The EMRs, electronic medical records. I could see them integrating some of this AI and really hopefully helping physicians and obviously ultimately helping the patient. So
Sure. Exciting stuff. What's the next big thing then for innovative pain specialists? What's going to happen in 2024 that everyone should know about?
2024, I don't know. I don't know what to say. I mean, we pride ourselves on helping patients. We pride ourselves on trying to get patients in as soon as possible so that we can help them and kind of move them along and steer them along so they can live their life and they don't need to keep being bogged down with seeing docs. But for us, I don't see any significant drastic changes. Again, we just talked about AI. It'll be interesting to see if how that can play into something. And we're always keeping our ears and our nose to the ground to see if there is anything that we can implement into our practice to be more efficient and help our patients out. So anything that ever comes around that is a good opportunity. There's new surgical techniques. There's new interventional techniques that are always coming out. Medicine is dynamic, and so there's always these different things that we can offer our patients and offer them for long-term solutions for sort of chronic pain and those are always beneficial to have, and things will be changing and we will have those constantly year after year after year to have those options available to provide to our patients.
Fantastic. I'm going to give you some rapid fire questions to end the show. Are you ready for them? It's just 4 questions, nothing too
Yes,
crazy.
no.
What's that?
Is it going to be like a Senate hearing committee where it's like yes, no, or what?
Oh no. No, I'm going to need, like a 10-second answer from you.
Okay, I'll get it 10 seconds.
Okay, so Greek heritage. What
Yeah.
is the best Greek dish to eat? What is the best place in the US or even in Chicago to get the best Greek food?
Oh, best Greek dish. I mean, me personally, I like a good bronzino, which is like a Mediterranean sea bass where they put olive oil, lemon, salt, pepper, oregano. Italians have the same thing. It's similar kind of food. And then you sear it a couple minutes on each side. It's really good, flaky, really good.
Mm-hmm.
I do like lamb, obviously. Just even standard lamb chops. There's a lot of American kind of style Greek food, which is like pasticcio and moussaka, things like that. Those are
Mm-hmm.
okay. I feel like they're a little bit more Americanized, but good seafood, good Greek seafood, good Mediterranean seafood is really when people do it good, it's
Incomparable. Yep.
it's incredible. There's a couple places in Chicago that have opened up. There's a Greek place in Winnetka. I think they have one in the city now. I think they actually have one up in Milwaukee. If I'm not familiar, I read an article that Giannis Antetokounmpo, the basketball player for the
Yeah.
Bucks, he invested in. It's called Avli. They're pretty good. They do some good food. There's another one in Niles area, so it's a little bit out. It's called Platia. They're pretty good, authentic Greek. And then there's 2 places in the city. One called Taksim, which is more like Byzantium food, which is sort of
Oh.
like you get from the Greeks that were more like in the Byzantium era, like Constantinople. They do a great job over there, as well as a place in Greektown, Nine Muses. Greektown's not as big as it used to be. It's sort of shriveling now that it's getting, it's all these newer kind of fads. Huge apartment complexes, condos are all being built up, so they're getting kind of phased out. But
Mm.
the uses down there were good. So I know I gave you 4, but those were kind of the places where I hit up. There's a couple other places I may not be remembering off the top of my head, but there's some good places around the areas.
Those are good ones. What's your favorite Thanksgiving dish?
Um, Good turkey. I bought a fryer last year, and I wanted to fry turkey this year, but I got poo-pooed.
Mm-hmm.
I was hoping to do that because it was really good when we had it last year. So turkey's great, and I do like stuffing, good stuffing, like an oyster stuffing, oyster dressing stuffing. That's really
Oyster
good.
stuffing. You bet.
Yeah. And what else is good? I don't know. I always like to see what kind of what the cornucopia of
Yeah.
when you're here, then everybody's like prepped for it, and you're kind of like you're like, okay, what do we got here? What do we got here? Oh, we got something a little different. So
Yeah.
what about it yourself?
I'm a green bean casserole guy with the fried onion rings on top. I think
Oh
that's
yeah,
always good.
that's a good one.
This might be an Iowa thing. I don't think it's made its way outside of Iowa. Macaroni corn bake. You ever had that? It's
So
like
what is this?
macaroni and
You cornbread
macaroni
and
and it's no, it's macaroni and cheese, a ton of butter, like 2 bags of corn, and then even more cheese, like a bunch of shredded cheese
And then you
and some
make it
whole
like a
milk in it.
mass.
Crock pot. You just put it in
Okay,
a crock pot, and it's just like really thick mac and cheese with corn in it.
that sounds pretty good.
So now it's one of those like you save that for last because if you start with it, you're not eating the rest of your food. It sticks to the ribs.
Yeah, I can imagine that. That actually sounds good. That sounds anything in a crock pot is usually good, but anything with macaroni, good amount of cheese and corn too. I mean, that's
I'll
good.
I'll send you the recipe,
Yeah,
but
send me a recipe. I'll have to maybe after Thanksgiving we'll have to do it on a cold winter's night and put it in the
there
old
you
crock
go.
pot.
There you go. We are both big fans of whiskey and bourbon. What is your favorite whiskey?
I like Willet. Willet's really good.
Cold winter night. There you go.
Winter night, very smooth. Willet's good. Buffalo Trace is good. Four Roses, the reserve, really good. Um, Smoke Wagon from Nevada is pretty good too.
Mm,
That one's a little bit more has a little bit more bite on it. It's not as smooth as some of the Kentucky ones. There's so many bourbons out there nowadays.
so many.
It's like you turn your head and there's another bourbon. A lot of these pop up places in different states. Obviously, every state in the union has some bourbon that they're making a rye or something like that. So I'm always interested in trying what is available, but I do like to the stuff that comes out of Kentucky is kind of hard to beat. I feel, but I feel that just anything that's nice and smooth is always nice to kind of sip on and relax for an evening. So I'm a big bourbon guy and wine too. I like to enjoy with my wife when we have
That's
some
right.
opportunity to have a glass of wine is always nice. So
For sure. Love that. Buffalo Trace. I was always a fan of Buffalo Trace until they really got commercialized. They became just a big network. Basil Hayden's is another one
yeah,
that
Basil
it
Hayden's
just it sits pretty smooth. Last one. Are the Bears going to win this weekend?
no.
No.
Hey, who are they playing?
um, I think it's the Carolina Panthers. I
Oh no, they already
uh,
beat. They already did. They already
they
play
already did
Carolina.
that. I might be wrong. I probably should have looked before I asked that
Again, I don't
question.
know who
Better
they're playing, but
research,
I
but
mean, dude, that's always I mean, listen, man, I've been a Bears fan my whole life, and
mhm.
I grew up in Lake Forest, so the Bears used to practice. They still do, but they used to practice in the old house hall, which was now part of Lake Forest College, East Lake Forest, and we used to, I grew up with the '85 Bears, so I used to go over. You used to be able to run over to the fence, and you used to be able to see the, guys would just like come right up to the fence, and you could literally almost reach out and touch them and talk to them.
Mhm.
You always in the problem with Chicagoans in the mind of Chicagoans, we always think of the '85 Bears, no matter what.
Yep.
Our comparison is always like, okay, is this like the next '85 Bears? Because that's all we really had. And I mean, yeah, they were good with like Ditka and Butkus and Gale Sayers and all those guys, but really, that pinnacle of the peak was really just that '85 Bear team, and everything pales in comparison. And when you get that team that's kind of coming up right now, we have I've kind of lost a little bit of I've lost a little bit of hope, but I've lost a little bit of I'm not following them as much as I was. But
Yeah.
I do have a prediction though. The Bears will lose. That's almost a guarantee. So I don't even know if that's really a prediction. But and it doesn't matter who they're playing, they'll lose. But or they'll find a way to lose. They almost beat Detroit the other day, and they blew it in the last
Hmm.
2 minutes. So, but I will have this. This is my prediction. My prediction is, and again, I could be wrong, but my prediction is that they're going to let go of their coach, and Jim Harbaugh is going to be the next coach of the Bears
Ooh. Next year or just whenever?
next year. I think Harbaugh is done. I think he's had a couple investigations, and they I believe they retracted his contract. I could be wrong on that. I'm not sure, but I thought they'd retracted his contract. So that's now in limbo. And I think he's
Hmm.
in some issues. And I think ultimately he wants to get back to the NFL. And I think he had a great time when he was in San Francisco. And I think
Hmm.
he did really well. And I think now he's thinking that, okay, how do I get back? And I believe a couple of years ago, or maybe it was a year or two ago, the Denver Broncos were potentially interested, but he stayed. I think he's waiting for like a storied franchise. Not that the Broncos are not, but he's waiting for like a
Yeah.
nice storied franchise to come around. And I think the Bears would be pinnacle for him because he used to play for the Bears. I mean, he played for the Bears for a long time, and he's sort
Oh,
of had that love, maybe for the old school Bears. That's my prediction. I could be wrong, but I think that
You might be onto something.
I think they're gonna let the head coach go, and then they're gonna figure out, are they gonna get a better coach in there to develop Fields, or do they let Fields go too, and then they get a new guy, a new either a rookie quarterback, and let Harbaugh sort of mold him into what he wants to have.
Yeah, I
We'll
just think
see.
Fields. Yeah, I think Fields is amazing. I think that's a great prediction.
I think
He does
Fields.
want to get
I
back
think
to the
Fields is a
NFL.
great quarterback. I think he's a skilled athlete, but
He's in his head.
he's not meshing right now with the system. And look, I mean, look, you know, there's some guys that do great with different coaches. I mean, you know, sometimes you have to have a good relationship with your coach to, you know, and then you exceed. And it's just like guys that run corporations. There's some guys that run corporations that do very well, and then when they go to other corporations, they're just not as successful. And it's whatever the environment is. And I think Fields just right now, I mean, you know, they always say the Bears is where quarterbacks come to die. And you know, it's sort of true. You know, every time you see it, we really haven't had, you know, a really good quarterback in almost. I mean, was it Sid Luckman, and I think I know McMahon, but I don't think McMahon was like the
Hmm.
revolutionary best quarterback. I think he was just at the right time, right?
Yeah,
I
good
mean,
at the time. Yep.
an outstanding team. He had a good couple of wide receivers. He had an incredible running back that you didn't really have to throw the ball. Just make a few passes here and there, and you'll be just fine.
Yep.
Are you a Bears fan in Iowa, or what kind of fan are you?
Chiefs fan.
Chiefs.
So,
Okay.
yep, I've been a Chiefs fan my whole life. So my worry, I was a Chiefs fan when they weren't good. So my worry is for young kids these days, they're just going to get so used to this Mahomes era that when he's gone, you know, they're just that's when people are always going to look back at the Mahomes era. And so kind of like the 85 Bears, I just feel like 20 years from now, everyone's like, yeah, the Chiefs aren't very good. They're losing all the time. Man, if we could just go back to, you know, the late 20 or the early 2020s, like
Yeah.
when
Yeah.
Mahomes was running the show, it's like, oh, that's going to be our pinnacle. So
Right. And when
that's my
he's
worry for
gone,
my kids. Yeah.
no, right. And then when he's gone, you're right. And then what's going to happen? If him and Andy Reid leave, it's like, does it kind of? I mean, you look at what's kind of happening in New England.
Mm-hmm.
I mean, it really. I mean, Brady's gone. They're talking about
Heck of
Belichick.
a heck of a 20-year run, and then it's like,
And they had a
yeah.
run. They had a run. They had a run. They were a dynasty, and they had a run. I mean, it was just like, you know, I was growing up in the, in the early '90s. I mean, it was the Dallas Cowboys with Emmitt Smith and
Mm-hmm.
Troy Aikman. I mean, they were just running the show. You know, even the Buffalo Bills. Remember, they went to like four Super Bowls in a row and
Yeah.
lost all. So I mean,
Yep.
they had played the team too, but they just didn't come up on top. You know, and it is what it is. But the Bears. I mean,
The Bears.
you kind of just you kind of put it on Sunday, and you're like, just some background noise while I'm doing stuff. So gets you through till Monday, I guess.
You bet. Well, I know this episode is not going to be some background noise that gets people through Sunday. I appreciate you coming on. Your insights were fantastic. There was a bunch of takeaways that people are going to learn from hearing you over the last hour. So I appreciate you taking some time out of your day here, right before Thanksgiving is when we're filming this. So wishing your family a happy Thanksgiving, wishing you all the best, and we'll be in touch.
Yeah, happy Thanksgiving to you and your family too, and thank you for having me on. I do greatly appreciate it, and I appreciate the good camaraderie with talking about even things outside the realm of medicine. Sometimes it's always nice to kind of get your hands on other things to talk about.
You bet. Next time I'm in Chicago, we'll have a bourbon, and
Yeah,
we'll talk about how good the Bears are.
yeah, well, that's going to be must be a 20 years from now.
Yeah. Talk to you later, Dr. Lewis. Appreciate
All
it.
right, you'd be good to have a happy Thanksgiving. Thank you.
See ya. Hey, everyone. As we wrap up today's episode, I want to talk about the second opinion. As most of our listeners are physicians, you guys know the importance of having another medical professional's insight for a patient's treatment plan. But have you ever considered having a second opinion on your financial plan? Or have you simply trusted your financial advisor that they've already leveraged every strategy that your family needs to be 100% on track to meet your financial goals? That's why, for my Doctors and Dollars listeners, each Wednesday I block off 3 time slots, an hour each, to provide a free second opinion of their financial plan. During this hour, we'll reevaluate your financial goals and your risk tolerance. We'll ensure tax mitigation strategies are in place and ultimately give you confidence with your financial outlook, because that is what drives a happy home, a happy marriage, and peace of mind. These 3 spots each Wednesday do fill up fast. send me an email at nate@grandvision.co or head over to www.grandvision.co/second opinion to fill out a quick form about you and schedule a time for us to meet. Thanks for tuning in, and I hope the rest of your week is abundant. Cheers.